Thank you, Brian. Brian Jacobs is a good friend, and I'd like to thank him very much for inviting me. I'd like to thank SAGES to allow me to come on the podium to talk. And it was a difficult presentation to start with, when not to operate. And knowing that, putting that in mind, we decided that I'm going to talk about different types of hernia. So I weaseled out of the tight position that you put me in.
Good.
So hiatus hernia, we know that we operate hiatus hernia if it's persistent or recurrent symptom despite medical therapy, GERD complications, patient desiring to discontinue medical therapy for the chronicity of its use, the cost of those medications, ineffective medical treatment at the end of the day. And I'm going to put the question in the other way. When to repair hiatus hernia? Sliding hiatus hernia, type 1 hiatus hernia in the absence of reflux disease isn't indicated, but in symptomatic, so indications are mentioned before. So it's not routine to repair type 1 hiatus hernia. If the indication happens, like developing GERD, then there is an indication. Paraesophageal hernia, if symptomatic, always should be repaired, should not wait to the complexity of these symptoms to develop. If asymptomatic consideration of the surgery, that should include, for example, sex and comorbidities, consideration of risks taken going under the anesthesia for different comorbidities involved. In other words, risk-benefit factor measurement. Acute gastric volvulus, upside-down stomach, or complicated paraesophageal always requires surgery, sometimes with limited restriction if needed. Routine repair of hiatus hernia during bariatric surgery, we find that it is definitely an indication and preferred to minimize the complication of hiatus hernia. For example, during LAGB, Roux-en-Y bypass, mini bypass, sleeve gastrectomies, because we have seen that leaving those wide hiatus have played a role in post-operative increased risk of GERD. The complexity of this diagram makes me hate to think when to operate and when not to operate. But at the end of the day, we find that doing an EGD for patients that have persistent GERD symptoms is very important to rule out other pathologies, like, for example, Barrett's esophagus, starting biopsies to take from the end of chronic situated ulcers in the lower esophagus, rule out malignancies. For that would give you a different modalities of management that might not be taken, and a simple hiatus hernia repair in that matter would be contraindicated. Sport hernias. This is, 5 objective signs: deep groin and lower abdominal pain, pain exacerbated with sport-specific activities and relieved with rest, palpable tenderness over pubic ramus and the pubic area, pain with resistant hip abduction, pain with resisted sit-ups. I'm going to present a shy number we had of 6 patients who are doing intense sports. Actually, they were football players in the Premier League of Saudi Arabia, which is becoming an important league, recruiting a lot of Brazilians, no Americans, but a lot of Brazilians and Germans and English players. So those 6 patients, 3 patients treated with a multi-modal approach, joint and soft tissue manipulation techniques, stretching, conservative, no surgery. And 3 patients preferred to have surgery. The 6 patients returned to sport 100% of peri-injury level within 6 weeks. In conclusion, surgery isn't always an indication. And the 6 patients have presumed playing active sports. Again, a very complex diagram. At the end of the day, the need of surgery in those patients is the failure of conservative management, exercise, physiotherapy that lasts over 8 weeks, then the need of surgery. And that is no guarantee of the pain being gone if you repair those hernias. But other things could be detected, like small pubanoceles, small femoral hernia that gets clipped inside and released every now and then. In that situation, those patients have to be operated. Inguinal hernias. If asymptomatic hernia or minimal symptomatic small hernia, uncomplicated, watchful waiting is advised to minimize unnecessary herniorrhaphy pain syndrome that can follow in those patients. In our clinics, we have seen up to 10% of those patients post-operative come to us with post-herniorrhaphy pain syndrome. The elastic bands used by athletic provide useful support for small hernias. In conclusion, not every inguinal hernia needs surgery. Patients' comorbidities and age play a role also. Umbilical hernia. In liver cirrhosis and ascites, high operative risk and increased recurrent rate and increased chronic leak of ascites from wound of a hernia repair can happen. But conservative management can also lead to severe complications which might lead to high risk of morbidity and mortality. Prospective and retrospective series shows elective hernia repair in those selective patients is safe when done in the optimum of time with the minimal complications, but you need to choose the optimal timing for surgery in favor of patient survival and success of your surgery. So ascites isn't complete contraindication of repairing an umbilical hernia. Conclusion, hernia in general can lead to major catastrophe if left untreated, but you should know when to operate and when to say no, depending on the patient's general condition, comorbidities, age, in addition to type of specific hernia. Thank you.